Welcome everyone. My name is Henrik Axelsson. I will be moderating this webinar today. The webinar is organized by the Health Economics Exchange Forum of the Afghanistan Ministry of Public Health, which is an online forum for health policy and financing among experts in Afghanistan, the region, and globally. The webinar is supported by the USAID Health Sector Resiliency Project. The topic of the webinar is Leveraging Provider Payment Reform to Improve Efficiency at National Level Hospitals. What can we learn from the international experience? Why has this topic been chosen? Because many low and middle income countries are implementing or considering provider payment reforms. And some countries are considering the introduction of global budgets to improve efficiency and increase utilization by enabling hospitals to better respond to local needs. We will learn about provider payment methods and the international evidence on global budgets, including insights from the experience of Thailand. We encourage you to submit questions during the webinar. After the three presentations, there will be a questions and answers session. The webinar will be recorded. I would like to remind our speakers to mute themselves when not speaking to avoid background noise. Thank you, and once again, welcome to this webinar. Before we begin, I would like to explain how the webinar system works. You will find the webinar control panel in the top right corner of your computer screen. In the top left corner of the control panel, you can hide and unhide the control panel by clicking on the orange arrow. The icon below the arrow will enable you to view the screen in full mode. The raise your hand icon will not be needed. At the bottom of the control panel, you can type your questions to the speakers. You can enter questions at any time during the webinar, but we will address them after all the presentations. Before we turn to the introduction of the speakers, we are honored by the presence and participation in this webinar of His Excellency, Dr. Ahmad Jan Naeem, the Deputy Minister of Public Health in Afghanistan. Welcome, Your Excellency. We have a very distinguished group of speakers with us today. We are very pleased to welcome Dr. Farhad Farwar, Director, Health Economics and Financing Directorate, Ministry of Public Health in Afghanistan. Dr. Viroj, Senior Advisor, International Health Policy Program, Ministry of Public Health in Thailand. And Annette Osaltin, Health Financing Specialist, ThinkWell, Health Sector Resiliency Project. I will provide further information about each speaker before their presentations. We are honored by the presence of Dr. Farwar, who is the technical lead in the Ministry of Public Health of the ongoing process of provider payment reform in Afghanistan. He will provide an overview of Afghanistan's health sector objectives and current health financing arrangements in the context of provider payment reform. I would now like to give the floor to Dr. Farwar. Dr. Farwar, please go ahead. Dr. Farwar, are you there?
Yes, Henrik. Good afternoon, everybody. Let me first appreciate His Excellency the Deputy Minister for his presence to this forum as a sign of Ministry of Public Health high-level commitment to the provider payment mechanism in Afghanistan. What I would like to present here is the policy context in relation to reforming provider payment in the country. What I would like to present in this, cover in this presentation are key policy objectives to be addressed by the provider payment mechanism. Next slide, please. Current financing arrangements for hospitals, existing gaps and challenges, overcoming the challenges through a number of reforms that Ministry of Public Health would like to introduce to the hospitals, among which the provider payment reform. Next, please. So the key policy objectives the Ministry of Public Health would like to address through reforming the provider payment mechanisms and a number of other reforms in the pipeline are improving efficiency in health service delivery, increasing utilization of health services, improving quality of health services, and also promote autonomy at the hospital, in hospital management. Next slide, please. What is the current situation of financing hospitals? According to the National Health Accounts 2014, around 40% of all expenditure to health goes to hospitals. And out of the 73% of the total health expenditure that goes out of the pocket, around 14% is spent on the hospitals. Currently, hospital services of essential package of hospital services by the NGOs and hospital reform project are delivered at a provincial and regional level, while the national level has remained somehow underfunded. Financing to the projects are taking place through the development budget of the Ministry of Public Health of Afghanistan. Please. And at the same time, what I would like to tell is national hospitals are currently semi-autonomous. Next slide, please. So before the reform took place in 2012, the hospitals were the main implementer of the services and with no authority over financial and procurement management of the hospitals, and also usually there has been delay due to in supplies and medicine due to weak procurement management both at the hospital and ministry level. There also has been mismatch between the need and the available resources provided to the hospitals, which has been exacerbated by the structural disconnect between the procurement and financial management and operations, one of which was located at the hospital, and the other was taking place through the Ministry of Public Health, which also provided procurement and financial management services to the whole Afghanistan. Next slide, please. So after the reform, still the budgeting mainly flows based on the past year expenditures through a line item budget mechanism following the government of Afghanistan system of accounts for both salaries and assets. And the only difference from the pre-reform is somehow we have authorized the hospitals to do procurement at the national hospital level, but that is also within the budgetary limit. Next slide, please. So currently, national hospitals are financed through the government ordinary budget, though the national hospitals are increasingly involved in planning their budget, but mostly Ministry of Public Health Finance Department negotiate their budget, and then they are the liaison between the Ministry of Public Health Hospitals and Ministry of Finance, who approve the final budget for the calendar year. Next slide, please. So after the autonomy has been introduced to the hospitals, there has been a considerable improvement in delays compared to previous years. Also, since the hospitals has made procurement for themselves, so there has been a better match between the actual need and also what has been made available to the hospitals. Service quality has been improved, and as a result, there has been corresponding improvement in the utilization of health services. Also, due to autonomy to the hospitals, there has been somewhat reduction in the workload of the Ministry of Public Health staff at the central level. Next slide, please. So still, with that also, we have still some challenges ahead, because still we are providing hospitals the line item budgeting, and though we see the hospitals are underfunded, still we are providing services for free, and the line item budget do not provide the need-based opportunity for need-based spending, and also the hospitals at the same time, there is no motivation and incentive for the hospitals to gain efficiency. Poor management information system, and also the inadequacy in financial management, or other problems that we believe that to be addressed through different reform initiatives. Next slide, please. In order to overcome challenges, the Ministry of Public Health leadership intends to grant autonomy to the hospitals and make, in order to improve their performance and make them more accountable to the population. And also, what we intend to do is to provide budgets based on the actual need of the hospitals, rather than based on the past expenditure, and also. So with improvement in the provider payment, we expect that there would be efficiency at the hospital level, and also that would enhance innovation at the hospitals. Also, with the provider payment reform, we believe administration costs will go down, and at the same time, Ministry of Public Health, through different initiatives, is in the process of outsourcing some of the hospital services, and also getting engaged with the private sector through PPP arrangements. And we also believe promoting progressiveness and PPP through PPP arrangements. So that's next slide, please. So why global budgeting? Because Ministry of Public Health in 2015 has conducted an assessment of the current financing arrangements, and as a result, there has been a consensus on going towards the global budget as a mechanism for financing the hospitals. The audience and also the participants believe that through introduction of the global budgeting, we provide incentive to the hospitals to be more efficient and also improve quality of their services. Hospitals will be more responsive to the patient's need. As you know, like it is relatively, the global budget is simple than the other provider payment mechanism available. It is also less costly, and going towards the global budget mechanism is as a first step towards the more sophisticated approaches, such as case-based budgeting, case-based payment. So that's all from my side for the policy context of the next slide. So thank you once again, and that's all from my side for the policy context for provider payment reform in Afghanistan. And I would like to learn from the other speakers on the provider payment reform in the globe and also in Thailand. Thank you.
Thank you so much, Dr. Farwar. That was a wonderful introduction to the Afghanistan policy and financing context. And it was also very helpful to hear how Afghanistan hopes to leverage provider payment reform to achieve health sector objectives. Thank you very much for that. We will now turn to Annette Usaltin. Annette is a global expert on health policy systems and financing. She has advised low and middle income countries on health financing policies and mechanisms. She was a technical facilitator of the Provider Payment Technical Initiative of the Joint Learning Network for Universal Health Coverage. Annette will describe the main hospital provider payment methods, and she will also present some basics on global budgeting and share lessons learned from the international experience. I would now like to give the floor to Annette. Annette, please go ahead.
Thank you for the introduction. I'd also like to thank the Ministry of Public Health of Afghanistan and the Health Sector Resiliency Project for this opportunity to speak with you today. So in my presentation, I'll provide a very brief overview of provider payment methods, and we'll share some lessons from other countries on their global budgeting system design. I'll present some considerations for countries transitioning, particularly from line item budgets to global budgets, and I'll conclude with some key messages. Next slide, please. Before launching into the different provider payment methods themselves, I think it's helpful to take a step back and ask, why provider payments? Dr. Farwar described the health system objectives in Afghanistan: increasing efficiency, increasing utilization, promoting hospital autonomy, and improving quality. Well, provider payment systems can have an important role in addressing all of these objectives. They help balance system revenues and costs to help countries expand coverage with limited funds, and they incentivize providers to deliver services more efficiently and to improve quality. They can also be used to increase equity and access. So first, some definitions. On the right, I've noted two definitions to orient us. The first is on provider payment mechanisms, which are the way providers are paid to deliver a covered package of services, compared to provider payment systems, which include the payment method to providers, along with supporting systems like contracting, accountability mechanisms, and information requirements. Next slide, please. The next two slides are a little dense, I apologize, but are aimed to describe the main hospital provider payment methods and the incentives they create for providers. The different methods are presented in terms of increasing level of management capacity that's required from the purchaser and providers. Afghanistan is now paying providers through line item budgets, which can be useful when cost control is a top priority and when financial management and monitoring aren't the strongest. But they have a real downside as they incentivize providers to underprovide services, increase referrals, increase inputs, and spend all of their remaining funds by the end of the budget year. So there's no real incentive for improving efficiency. With global budget systems, cost containment is also a top priority, but providers receive a fixed amount of funds to cover their expenditures. And payment is made in advance for an agreed upon set of services, and then the budget managers can reallocate expenditures across line items as they see fit for efficient management. Global budgets create a variety of incentives for providers that impact efficiency, quality, and access, but they differ in an important way depending on how the budget is formed. For example, if a global budget is formed based on inputs like staff or beds, the incentives can be the same as line item budgets. Although in this case, providers don't spend their remaining funds down at the end of the year. But if the budget is formed based on volume or outputs, the incentive is to increase the number of services, increase referrals, and decrease inputs. Next slide, please. Fee-for-service, per diem, and case-based payment are other hospital provider payment methods. And within global budget systems, some countries use these activity-based payment methods to pay their providers. But because of our time constraint, I won't go into these methods now, since the Ministry of Public Health is considering a transition from line item budgeting to global budgeting. Next slide, please. When choosing among the different payment methods, there's no perfect method, unfortunately. And standalone, each payment method has strengths and weaknesses when it comes to meeting policy objectives. At the same time, all payment methods can be useful at particular times or in particular contexts. The table here presents the inspected impact of payment systems on health system performance. You'll see circled in red that for global budgets, the expectation is for increased expenditure control, but with an associated decrease in activity, both in the number of cases and the number of services per case. And the impact of global budgets on technical efficiency and quality is neutral or unclear. We'll revisit all this later in the presentation. But you'll see that each method alone has difficulty in meeting a range of health system priorities. So often countries will blend payment methods or add adjustments to the traditional payment methods as a way to tackle some of the efficiency, access, and quality challenges. So some examples can include global budget systems with case mix adjustments, which you'll hear about a little bit later from Dr. Viroj, or global budget systems with explicit pay-for-performance components to them. Next slide, please. When determining which payment method might be best for a particular context, countries should evaluate the strengths and weaknesses for the impact of the incentives on the health system priorities of the country, the capacity of the purchaser and capacity and autonomy of providers, and other contextual factors as well, such as the political and legal environment or any dynamics between the purchaser and providers. Next slide, please. And now for global budget system trends. There is a lot of experience for Afghanistan to draw upon in considering the introduction of a global budget system. Now, lessons can be primarily drawn from the OECD countries, the emerging former Soviet countries, several Southeast and East Asian countries, among others. But it should be noted that most of the countries that adopted global budgets, with a couple exceptions, were middle and high income countries at the point of their introduction. Currently in OECD countries, global budgets and DRGs are the most commonly used methods of payment for public hospitals. For inpatient care and outpatient specialist care, almost half of the OECD countries use global budgets as their main or one of the main methods of payment. So really popular now. Next slide, please. This table shows trends in adoption of global budgets in the World Bank, Europe, and Central Asian region. You'll see that over half of the countries had introduced a global budget by 2004, and the adoption trend has continued since. The number is higher today. Next slide, please. So why global budgets? As we saw some of the incentives they create for providers. For a whole host of reasons, many countries have considered global budgets attractive. The primary reason being to give purchasers more control by allowing them to contain their costs. Thus, purchasers have funding certainty, but so do providers. Global budgets give providers more autonomy, and they're responsible for their own spending. So they use their judgment on how to use their limited budget to serve their patients, which can encourage them to operate more efficiently. And global budgets can also improve quality, increase efficiency, and change service delivery patterns. But this needs to be when they're combined with incentives, penalties for non-performance, and routine monitoring. So this is the distinction of global budget standalone with these accompanying measures. And finally, relative to other provider payment systems, Dr. Farwar mentioned this, global budgets are seen to be administratively simple and cheaper, requiring less sophisticated information. Next slide, please. So how are global budgets used? There are three different ways. First, they can be used as a resource allocation mechanism, where a system-level cap manages global allocations, but then providers are paid based on outputs. The second and third ways are where global budgets are allocated to providers specifically as a provider payment system, which we'll talk about for the majority of today. And as a provider payment system, the global budget can be allocated either through a lump sum budget that's formed based on historical input use or volume, or could be formed through payment for outputs, but only up to a provider-specific cap. The first and third examples here, as resource allocation mechanism or payment system with volume-based payments, these illustrate the relationship between global budgets and activity or output-based payment. These options really provide the greatest potential for countries to fine-tune some of the incentives within global budgets to achieve health system objectives. Next slide, please. Here is an example from Taiwan, which presents an interesting study of using a global budget at the system level. Here, the providers are paid based on activity under a global budget. So Taiwan makes resource allocations with a systems level cap for 4 different health subsectors: the dental sector, traditional medicine, clinic-based services, and hospital-based services. And then following these caps for each of the subsectors, Taiwan divides the subsector budget into 6 regional global budgets. If you look at the timeline on the far right, you'll see that Taiwan introduced a global budget system in 1998. They moved from fee-for-service and case-based payment to a global budget system under which a combination of activity-based payment methods are used. And so Taiwan can retain the cost control lever of the global budget, but also incentivize providers to be productive and efficient through activity-based payment. Next slide, please. The remainder of the presentation addresses allocation of global budgets to providers as a provider payment system. So in these cases, probably the most important policy decision is the basis for payment, which is the set of units that form the budget. This determines the financial incentives of providers to reduce expenditures. And when I introduced global budgets earlier, I addressed inputs or outputs-based budgets and highlighted some of the incentives they create. They're noted here again. The budget can also be formed based on volumes and types of cases, case mix, which you'll hear Dr. Viroj present on soon. The table on the right shows a few examples by country on the basis for provider payment. So there's quite a range. This is just a snapshot. Now, input and output-based budgets have some unintended consequences, which case-mix-based budgeting can address, which is really the gold standard of creating incentives for productivity and efficiency. Next slide, please. In addition to the basis for payment, there are many other decisions that need to be considered in designing a global budget system, and I'll just highlight a few from this list. A very important one is the method to define the covered population. Another is the services to be included, which can be defined in various ways, such as the sectors of healthcare, which we saw in the Taiwan example, or specific services of facilities or treatments. Also to be determined are the expenditures that will be covered outside of the global budget. These are often capital, training, research, other costs that may be allocated through a parallel global budget type system. Another decision relates to how the budget will be set. What are the rates that will be used to derive the budget? This can typically be historical expenditures. It could also be historical expenditures with a mix of per capita expenditure and then norms for efficiency built into. So there are a variety of ways here. And finally, all the implementation arrangements that go along with introduction of a global budget. So what are the supporting laws? What is the routine monitoring system for quality? What are the associated rules for public financial management and so on? Next slide, please. There is no one-size-fits-all global budgeting system, as there are many different design decisions that can be taken. And I wanted to quickly flash this chart to highlight the variation in global budgeting systems in 9 different countries, based on the services that they cover, the expenditures they include, and the action taken if providers exceed their budget. So a lot of variation, no one size fits all. Next slide, please. We addressed some of the advantages of global budgets, but what about their impact on efficiency and quality? First, on efficiency. When compared to line item budgets, global budgets do indeed permit more efficient use of resources, but by themselves, global budgets have weak incentives to provide services efficiently. The table on the right is the one I introduced earlier, indicating an unclear impact of global budgets on efficiency. So they do contain costs, but their impact on activity levels can affect their ability for efficiency. And experience does show that global budgets based on inputs or historic spending alone have not resulted in an efficient use of resources. And so gains in efficiency depend on how global budgets are set and the extent to which hospital managers are accountable for their performance. In their design, they must be able to change the flow of payments over time and have accompanying incentives for efficiency. So where management responsibility is effectively decentralized, we'll talk about this later, and where providers benefit from productivity gains. So incentives for efficiency are not diluted. Next slide, please. On quality, experience has shown the importance of routine monitoring to detect any unintended consequences of a global budget system to keep costs down. So for example, providers may ration services, skimp on care, or skim cream from the top as a way to keep under their budget. And so a routine monitoring system and measures should be introduced to counterbalance any adverse effects of cost containment on quality. Incentivize good provider performance and penalize poor performance. A few key performance indicators related to quality and access could be helpful in an initial rollout of a global budget. On the right in the box, you'll note a few potential KPIs that the countries have used. And although not easy to monitor, without these measures and tools, the global budget may be little more than a block grant, which is not ideal. As payment systems evolve over time, countries can introduce other measures to incentivize providers. They could consider paying for performance, provider benchmarking, and other means as well. Next slide, please. Contracts or health service agreements are important for specifying the terms related to the volume of services to be delivered and quality monitoring. They're really essential when budgets are not case mix based. And various contracting mechanisms can provide protection against skimping on care or reductions in access. So for example, to protect against excessive provider underspending, contract terms can allow providers to retain surpluses, but subsequent year budgets may be adjusted downward. Volume adjustments are another tool. They can provide providers either additional or reduced payment on the margin for any variance in activity levels planned. So this can protect against provider underactivity. And for example, instead of a 100 fixed cost global budget, a contract could have an 80% fixed cost basis with payments to providers at 20% marginal cost. Next slide, please. Global budgeting can be a useful interim step between the use of line item budgets and the adoption of activity-based payment methods. The successful management of the budget, to achieve successful management of the budget, providers must have the autonomy, authority, and responsibility delegated to them. Budget managers need to have significant control over personnel, and they must be accountable for their performance. And regulatory systems need not be overly harsh. But introduction of autonomy can be phased, with management capacity building really a critical element of the transition. And there are also other considerations for phasing in a global budget system over time. For example, evolving information and billing systems, including more services or types of cases, increasing the capitation and performance-based percentages of the budget, and so on. Next slide, please. When thinking of transitioning to a global budget, it's important to recognize that provider payment reform never ends. It's important to continually readjust the provider payment system through learning over time. And this example of a roadmap from Mongolia shows their milestones over a 5-year period to move from an overall pooled budget cap towards budget caps based on volume, and also to introduce efficiency and quality incentives along the way. So even if these components aren't incorporated immediately, these refinements can be planned over time to achieve stated objectives. Next slide, please. I'd like to close by reiterating a few key messages. First, each payment method alone has difficulty meeting a whole range of health system priorities. So a global budget provider payment system alone may not be sufficient to meet all of Afghanistan's objectives related to efficiency, utilization, quality, and provider autonomy. To maximize the positive and minimize the negative consequences of global budgets, countries can introduce access, quality, and efficiency incentives and or activity-based payments in combination with a global budget. Importantly, the delegation of autonomy, authority, and responsibility to providers is key for successful management of the global budget. And finally, a transition period can be useful to enable management capacity to develop and ensure the continuity of services during the transition period. Next slide, please. I want to thank you very much for the opportunity to share with you today. I look forward to your questions later in the call.
Thank you very much, Annette. That was an excellent presentation. You had much to cover, and you did so very effectively. Thank you again for that. We will now turn to Dr. Viraj. And may I remind those who are not speaking to mute their microphones, please. And also, just to remind our participants to please submit questions in your control panel so that we can direct those to the speakers during that session. Dr. Viraj is a globally recognized authority on health policy and financing and has chaired and served on several global health commissions. Dr. Viraj was a key architect of the Thailand Social Health Insurance Scheme and the Universal Health Coverage Scheme, also known as the 30 Baht scheme. Dr. Viraj will share his insights from the design and implementation of global budgets in Thailand. Dr. Viraj, please go ahead. Dr. Viraj, can you hear us?
Hello, can you hear me?
Now we can hear you, Dr. Viraj. I just finished introducing you, so please go ahead.
Thank you, Henrik. This is a joint work by NHSO Tawisi and IHPP, Walaiporn, and myself, sharing the implementation of global budget from the Thai experience. Next slide, please. I have three outlines. After the background, we will discuss how global budget was applied to USC and what are the key lessons. Next, please. Next, please. Next, okay. Historically, we have 5 budget line items, which is applied to all public agencies, not only hospital sector, but also to school, to any public organization. Personnel, operating expenditure, capital expenditure, grant, and central budget. Please note that central budget is for unpredictable volume of demand of budget. For example, pension payment, contingency for national emergency and disaster. Budget proposal was prepared 1.5 years well in advance and endorsed by Budget Bill. And unliquidated budget will have to be surrendered by the end of the fiscal year, except capital expenditure, which can be extended beyond the fiscal year with permission. Next, please. These are the very complex funding stream of revenue to hospitals. If you look at left box with dot square, our pocket payment by household by the uninsured population, and our pocket payment to be insured under the voluntary health card scheme, which is premium. And government line item number 4, which is grant. They subsidize voluntary health card and also full subsidized for the low income scheme for the low income people. This directly paid into the hospital revenue, and it was kept and can be used by the hospital with flexibility, and of course subject to rigorous financial audits by Auditor General, either on site or audit of the report. On the right part, which is government budget in the brown, in the gray shade. Government budget, central budget for as an open end is to subsidize civil servant medical benefit scheme for the government employee, and this paid to the hospital, and become hospital revenue and was kept and used as at the hospital level. A contributory scheme, social health insurance, the SSO pay on a contractual basis to hospitals. That money become hospital revenue, and it become hospital revenue and used flexibly. The right column, the last box, which is government line item, which is more or less cost and budget to MOH health facilities. For example, capital investment, salary and operating. These are line item, and you cannot spend cross line item. So all these are the financial management in public hospital before 2002, for which we introduced USC. Next slide, please. After USC, on the left box, which is a dot red box on the left hand side, USC was managed by National Health Secretary Office. It consolidated A is low income scheme, B voluntary health card scheme, and mobilized new budget of $1 billion for 18 million uninsured. And D, consolidate the previously operating budget held by the MOH and managed by NHSO. And NHSO purchase service to public and private hospital, and this money become a hospital revenue. The government employee scheme stay as the same, social health insurance stay as the same. This revenue stream on a green arrow flow into hospital. The most critical change after UC 2002 is the right-hand box. The MOH health facility budget, operating budget was transferred totally. So that means the remaining is some salary for administration, for FDA, etc. And also major capital building and equipment for hospitals remain managed by the MOH. As a result, it emerged a provider-purchaser split mechanism for which MOH hospitals serve as a provider of services. Government employee scheme, civil servant is a purchaser, and social insurance is the purchaser, and the UC scheme, NHSO, is the purchaser. So this is the major transition within a year in 2002. Next slide, please. Now what? We apply global budget to USC. Next slide, please. After 2002, there are three schemes emerged in Thailand, covers 99% of the total population. The green shade is the UC scheme. The middle is the civil servant scheme. And on the right-hand side, the gray shade is the social insurance. All these are governed by law and cover the poor. 75% of the population, 50 million people, mostly rural people, live in quintile 1 and 2, the poorest and the poor quintile. Elderly mostly engaged in informal sector, and this is tax funded. And we use close-end budget and apply capitation and DRG as a main mode, and some fee schedule as a mixture of provider payment. And this is managed by National Health Secretary Office, governed by a board, which is chaired by the Minister of Health, and civil society. We have 5 seats out of 32 seats. So we have a civil society voice in the governance of the UC scheme. The most problematic is the middle column, which is civil servant scheme. They still apply open-end budget. Although they recently in 2008 they introduced DRG for IP inpatient services, but still use free-fall service for outpatient service, and that create rapid cost increase and system inefficiencies. On the right column, it is social insurance they apply cross-end budget and capitation, and more recently they introduced DRG. Therefore, in Thailand, for inpatient, we apply totally DRG with global budget in UC scheme, within global budget in social insurance scheme, and without global budget for the civil servant scheme. And very fortunate that we have a public dominant, non-profit dominant health system, whereby 78% of the hospital beds are public, and only 22 bed sites are owned by the private. Next slide, please. We published a paper in Economic and Political Weekly in India in 2012, saying that social health insurance, the SHI, is the pioneer on capitation. So that means SSO applied cross-end provider payment by adopting capitation since its inception in 1991. And we calculate 700 baht, which is around $28 per member per year in 1991, and today the capitation budget was around 2005 per SHI member per year. Next slide, please. This is a simple model of PQ approach in the estimate of capitation. P refers to price and Q refers to quantity of services. In 1991, we adopt this simple model of 3 OP visit per person per year, multiplied by unit cost of 150 baht per visit, plus 0.1 admission per person per year, which is 10% admission, multiplied by 300 baht per admission. So this combination come up with 750 baht per SHI member as a contracting capitation. But the SSO decided to adopt 700 baht, round figure, they round down, not round up. So that means the contractor hospital defined as more than 100 beds because SHI live in urban, they are urban workers. So they are familiar to hospital beds, but not health centers. They receive 700 baht per year, register with them. So 700 baht multiplied by X members. So this is the total sum, and you manage this to provide inclusive service for OP and IP in a year. An employee can choose to register with a preferred contractor hospital once a year. And this has been operated since 1991. And we find that utilization rate is quite optimum. Next, please. Now we also apply global budget using SHI 1991 as a precedent. Budgeting and purchasing design of USC since 2001 inception. We decide to apply global budget in 2 dimensions. One is global budget acquisition and allocation. So that means National Health Security Office cross-end annual budget acquisition to and allocation from MOF. So that this is the first dimension. And after acquisition and allocation, NHSO also execute budget using a mix of cross-end provider payment method from NHSO to healthcare provider. And this is the graphic presentation of the flow of fund from MOF to UC scheme managed by NHSO and NHSO purchase service, both using global budget and cross-end mechanisms. Next slide, please. These are the 3 main reasons that we adopt cross-end budget acquisition and execution in the UC scheme. First, SHI set a precedent since 1991 of applying capitation contract model with a very good cost containment and adequate access to care by members. Second, this is a no-go. CSMBS, the Civil Servant Medical Benefit Scheme, applied fee for service for OP and IP reimbursement model. So we see from empirical evidence showing that we see inefficient use of resources. We see a lot of supply-induced demand, volume, expanding volume, and charge more, despite the fact that most of the providers are public hospitals. So public or private hospitals are operating as an entrepreneur. They love money, they charge more. They love money to have more money in the hospitals. And also significant cost escalation as a result of this fee-for-service and overspending beyond the annual budget allocation for 2-3 decades. And finally, the third reason is fiscal constraint. In 2001, we have not fully recovered from 1991 Asian economic crisis, where GNI per capita was merely less than 2,000, and it was at the bottom of the crisis. Therefore, close-end budget execution through combination of close-end payment is the only choice, and we cannot afford to pay based on fee-for-service. Next, please. This is the negative impact of fee-for-service, very classic. The top line is the total expenditure of Civil Servant scheme. The middle line is the outpatient expenditure, and the lower line is the inpatient expenditure. After reform in 2008, 2009, and tight control, close monitoring of expenditure of outpatient, there's some sign of slowdown of expenditure. But after 2013-14, the curve, we don't have adequate time to produce update curve here. In 2014-15, the total expenditure has gone up again. So that means intervention to curb down fee-for-service by tight control has proved not effective. Next slide, please. The line shows GNI per capita. After economic crisis in 1997, GNI per capita has dropped down, but the crisis was translated into opportunity to introduce UC scheme in 2001, when the GNI per capita was $1,900 US. And within a year, we scale up population coverage from 71% to 99% within a year. And this is not only scale up population coverage, but a major financing reform, purchaser and provider split, and termination of supply side financing, and introduction of cross-end provider payment method. So all these are a major 3-4 reform in one setting. Next slide, please. This is how we request budget from the government, and we apply cross-end budget acquisition with a policy goal of cost containment and efficiencies. In annual budget estimate, we totally use evidence-based. Similar to SHI experience, we use apply PQ approach, which is unit cost multiplied by use rate for OP, for IP, and many other interventions, but more detail and differentiation compared to the SHI. And whereby multi-stakeholder has involved in the process of scrutinizing and oversight of the process. Therefore, Budget Bureau has lost the power of we call discretionary power in budget allocation, but they surrender to all this hard evidence of unit cost and utilization rate, and also total member being covered. Therefore, we are not making for money from the budget bureau, but the budget bureau has to allocate budget based on evidence, which is a political decision to go with UC scheme. The total budget requirement per year is the cost per capita for health services multiplied by total number of beneficiaries plus additional specific intervention. For example, ART, CKD. For estimate of ART, we estimate cost per person year multiplied by total case per year. Similarly to CKD, chronic kidney disease, to prevent the progression of the kidney function to end-stage situation for which it is too expensive. We end up with dialysis or kidney transplantation. Next, please. This is the fiscal reality that the budget request based on the scientific evidence, which is cost and utilization and total number of target population. These are the multiplication of unit cost, utilization, and total number of population, target population. And the fiscal reality, therefore, there's a gap between budget estimate and budget allocation in the budget bill, almost most of the year, except some year in 2008 and 9. In particular, when in 2014 we have a fiscal constraint and economic growth was sluggish at 2.5% GDP growth in 2014, 15, 16. Therefore, we are facing difficulties because UC scheme is solely financed by the general tax on annual basis. Next slide, please. Budget per capita has increased from 1,202 baht in 2003 to around 3,000 something in 2016. So this is almost threefold increase, and not because of the global budget and the efficient cost containment of capitation and DRG, but the cost driver are expansion of benefit package, increased utilization of OP and IP, unit cost inflation 3 to 5% annual wage increase, and medical product inflation. And you will see next slide. Next slide, please. This is a historical milestone of expansion of benefit package from a very basic, comprehensive in 2002. We expand usual ART in 2006, and in 2015 on ART we introduced detect and treat policy for HIV no matter level of CD4. So detect, treat, recruit, and treat. And also we introduced in 2009 renal replacement therapy with peritoneal dialysis first policy. We fully support hemodialysis and kidney transplantation. So all this cover and free of charge to the patient. All this slides funded mandate. So that means decision to expand new intervention into the benefit package come up with a full funding. So Thailand never promised unfunded mandate to the UC scheme members. Liver transplantation for hepatic failure in patients under 18 years in 2012, heart transplantation. All this include cyclosporin for rejection of graft, rejection, etc. Also inclusion of flu vaccine, etc. Next slide, please. So this slide just reflects what happened in the previous slides. On the left-hand side is the interventions or benefit package. And 2002, 2011, These are the percent distribution of capitation on the last row. Next slide, please. On the downstream budget execution, these are the most latest 2016 capitation budget, 147 billion baht on the last row, and 90.6% is within capitation, basic capitation budget, and 9.4% is additional budget for specific intervention, 9.4%. Most importantly, if we look at the provider payment method, we have a good combination of capitation or DRG with global budget, or point system similar to Taiwan system or Japan system, point system within global budget. Or for example, if you look at HIV/AIDS on B1, we also purchase medicine, centrally negotiate medicine, and use vendor managed inventory to deliver medicine ARV down to the provider level. So fee schedule, subsidized in kind, or some project based, etc. So these are the modification when the system become mature, start simple and become mature at the end. Next slide, please. Addressing high price of oligopoly medical product or monopoly medical product is one of the key strategic purchasing capacity of the NHSO. Between, if you look at the table here, the market price dollar per piece per unit of folding lens, of unfolding lens, balloon stent, Dark-Coat stent, alloy stent, and medicine, etc. And the negotiated price that NHSO purchased, and the total cost saving between 2011 to 12 for folding lens to 0.6 million US dollar. So these are the cost saving by centrally negotiated price we call monopolistic purchasing power. Total cost saving 188.3 million US dollar in these few years. So more cost saving, more service can be generated, and this cost saving will recoup its efficiency gain from monopolistic. We haven't have empirical evidence whether monopolistic purchasing power is more effective than global budget and DRG system in containing costs or not. But this is the empirical evidence saying that these are the cost saving. And this will recover the shortfall between budget allocation and budget request in the previous 2-3 slides. Next, please. What are the key lessons? Next, please. Global budget is the most effective instrument in achieving policy goal to contain costs and gain efficiencies. But it alone is not suffice. We need more strategic purchasing mechanisms in place. And when transferring financial risk to provider, we must accompany by adequate funding, which reflect full cost to provider, so that they will not abuse by not providing or undercut services. An appropriate parallel quality assurance and oversight mechanism must be in place, because the downside of capitation is under service provision, and the downside of DRG is DRG creeping. But we introduce global budget to cap the whole IP expenditure. No matter how some hospital has abused by creeping the DRG, by put more weight on, there are no any impact, any cent, additional cent overspend of that global budget for IP. Next slide, please. We need multiple interventions to contain costs. Primary care gatekeeper, for which we have introduced since day one. when health center and district hospital are main contractor provider, they get this capitation when they refer to provincial hospitals. They have to pay, and NSO has come step in and ensure appropriately flow and ensure that there are no overcharge by tertiary care hospitals. Second intervention is the cross-end provider payment that we have discussed at length. National list of essential drug, which is the reference for medicine package. The inclusion of new medicine into this national list, subject to rigorous health technology assessment. The incremental cost effectiveness ratio we apply less than 1 GNI per capita per quality gain as a benchmark. Beyond this, we will never adopt any new medicine. Also, introduction of monopolistic purchasing power for high cost or high volume or oligomonopoly medical products. And also inclusion of new intervention, not only medicine, but intervention into the benefit package is subject to HTA process. Next slide, please. We have reviewed the 9 cost drivers in the US healthcare. It is so notorious that they deserve because this is the system they create. High administrative, they apply fee for service. All this must be aware in reforming USC, for which provider payment and strategic purchasing very well designed system can overcome all these 9 challenges. Next, please. This is the final slide. What are the required institutional capacities? Data. We need rigorous, reliable evidence on unit cost and utilization for PQ approach for unit cost and use more detail there. We need institutional capacity to estimate total budget requirement and to develop and fine-tune DRG. Now we have our own homegrown DRG system now in version 5 point something. So totally managed and developed with multi-stakeholder oversight mechanism. So everyone owns the DRG. Version 5, now version 5.2, I think. We need a good governance and implementation capacities. Implementation capacity of NHSO in terms of strategic purchasing capacity and MOH and public sector provider capacities. All this are embraced in a good governance and evidence-based reform. Next, please. I thank you for your attention and look for Q&A in this call.
Thank you so much, Dr. Viraj, for that extremely informative presentation on insights from global budgets in Thailand. You shared many practical and important insights with us. Thank you very much. I would like to thank all the speakers for their excellent presentations. We will now turn to the questions and answer session. Thank you to all participants for submitting questions. We have about 15 minutes left in our webinar, and we have been informed that His Excellency, the Deputy Minister of Public Health of Afghanistan, would like to make some concluding remarks. We will have time for 1 question for each of the presenters. And also in the webinar report, we will include the questions and also try to address them, and we will share that with you after the webinar. So I would like to begin with Dr. Viraj. We have 1 question that has come in, which is, what are the key factors that motivated Thailand's move towards global budgeting? Over to you, Dr. Viraj.
Thank you, Henrik, for the question. I am one of the team involved in the reform since 1991 SHI. There are advices from international experts for social insurance to apply fee for service. At that time, we thought that capitation is not very well known in Asia. No any single country has introduced capitation. Therefore, we should have review the downsides of fee for service, of supply-induced demand and inefficiency, cost escalation, and fraud in the CSMBS at that time. We found that we should, as a new scheme, introduce capitation. And no one teach us how to estimate capitation. We do it by scientific footing of potential resource required for a person per year. For a service, what are the service OP? What are service IP? So the cost of service is the multiplication of utilization rate and unit cost. And at that time, we have unit cost. Therefore, we interject policy. The first Secretary General of the SSO agreed that with capitation, we can cover both outpatient and inpatient, whereby the international expert hired by ILO, International Labour Organization, saying that for fees for service, we only cover inpatient services. But our proposal for capitation, with this amount of money, we can cover both OP and IP. So this is a win-win solution and cost containment and efficiency gain and prevent abuse and supply-induced demand. So that is the first victory in the reform history of Thailand. Therefore, we continue to generate evidence what are the strengths and weaknesses of capitation, and what are strengths and weaknesses of fee for service, and publish and learn and form a group of reformists until 2002, when the window of opportunity opens, that we decided without any hesitation that we have to go with the closed-end provider payment method. At that time, we also parallel reform, which is introduction of DRG system by Supasit Panarunothai. He is the founder of DRG system. Therefore, I think it's part is the luck, part is the evidence, part is effective interface between evidence and policy decision.
Thank you very much, Dr. Viroj. Very helpful. I would like to direct one question that has come in for Annette. And the question is, if there is some flexibility in global budget payment mechanisms to provide incentives to health workers for good performance as a measure to improve quality of care. Over to you, Annette.
Thank you for this great question. I think incentives to providers offer a very powerful accompanying mechanism to ensure that global budgets are achieving their health system objectives, such as increased efficiency and utilization and quality. And certainly different pay-for-performance mechanisms do exist alongside global budgets. One example is pretty common, where providers can keep any surplus from coming in under budget and can use that surplus to pay providers. It could be a bonus system, and also to improve facility operations as well. So that's one measure where physicians, midwives, nurses, and other health workers could benefit from their better decisions and efficient practices. Another example is use of provider reporting alongside global budgets, where this can serve as an incentive for good performance, and it could also serve as a penalty for poor performance. So provider reporting on performance can have a both positive and negative impact. And I think one additional area is around provider benchmarking. So for example, when introducing quality measures that you would be monitoring for, one option would be to benchmark providers on their performance related to those quality benchmarks, and perhaps have that associated with some sort of payment incentive for those performing well in those benchmarks. So those are some options there. And perhaps Dr. Viroj might want to address any incentives in the Thailand system as well.
Dr. Viroj, would you like to pick up on that?
Yes, when the NHSO capitation budget come to hospital revenue, it is the decision by the hospital or that contractor provider network to pay. But paying staff incentive is covered by MOH rules and regulation. So it's possible, and we practice this as a regular mechanism. For example, we pay financial hardship allowance, we pay overtime payment, we pay for performance on additional number of services to staff, or we use this budget to hire contract workers on annual basis, contract workers. Over to you, Henrik.
Thank you very much, Dr. Viroj, and thank you also, Annette. We also have a question that has come in for Dr. Farwar. And that question is, based on the international evidence and the insights from Thailand, how do you view the feasibility of implementing global budgets as a provider payment method in hospitals in Afghanistan? Please go ahead, Dr. Farwar.
Thank you all for very nice informative presentations. We certainly understand that when going for reform of payment, a number of other changes has to occur at the same time to the hospitals, including providing autonomy to the hospitals as well. Presence of His Excellency Deputy Minister in this forum could be considered a sign of high-level commitment within the Ministry of Public Health that could also be used as a leverage with the government of Afghanistan when introducing the provider payment mechanism, as we say, global budget here. At the same time, when we work on the design of the global budget, we also consider some other issues, including what we say is the lower capacity at the hospital level in terms of the information and financial management. So also, we are in the process of finalizing the user fees regulation as a sort of payment to the providers that will accompany global budget when we plan to introduce it. So these are things that that makes us optimistic in implementation of the global budget in several national hospitals over the foreseeable future.
Thank you, Dr. Farwar, for sharing your thoughts and reflections on the implementation of global budgets. We would now like to give the word to His Excellency, the Deputy Minister of Public Health of Afghanistan, to make concluding remarks. And again, we would like to extend our appreciation to His Excellency for participating today. Please go ahead, Your Excellency.
Thank you very much, Henrik, for the excellent facilitation of this webinar. And I would also like to thank the speakers, that is Dr. Viroj and Ms. Annette Ozalton and Parivar, for the very excellent, presentations. And in fact, Afghanistan public sector provides, providers play a major role in delivering health services. Ministry of Public Health recently embarked, towards reforming the public hospitals, and one of the recent initiatives taken by the Ministry of Public Health in this regard is the granting of autonomy to national level hospitals, and further in which intends to implement global budgeting approach for national hospitals. It was a great opportunity for me, especially to participate in today's webinar. And from our side, we are committed to bring reform, and the reform process is very crucial, to learn from others instead of, inventing the wheel all over again. So the international experience that was presented by Annette, that was very rich, and it was very insightful, and we in the future may further work on design of global budget and towards its implementation at national hospitals. We hope that this will help our hospitals to be more efficient and better address the need of the population. Probably this is not the end of it, and when it comes to implementation, the devil is usually in the details. We will be looking forward, to more interaction through the Economic Exchange Forum. And the initiative itself, I like to thank once again my colleagues in EHFD for the leadership, and their leadership in organizing such webinars. I also would like to thank the USAID for and Palladium, for supporting the webinar, and this one was specifically intentionally, organized in the office of Palladium, to pull me out of, the visitors, that and some of the ministry's work there. So I'm grateful to them as well, and we are looking forward to working together. And thank you very much, everybody. And maybe some of you, or it may not be convenient for you, you're connected from different places. So I wish you a good day and nice sleeping, and thank you.
Thank you, Your Excellency, and thank you for taking the time out of your schedule to participate today. That's very much appreciated by everyone, and we're very pleased that you found the webinar informative. I couldn't agree more that it would be wonderful if we can build on this exchange and expand on the sharing lessons between different countries. So thank you again, Your Excellency. This concludes this webinar on provider payment reform and global budgets, organized by the Health Economics Exchange Forum of the Ministry of Public Health in Afghanistan, with support from the USAID Health Sector Resiliency Project. We would like to thank all the speakers and participants for your excellent contributions to the webinar, and we hope that you all found it informative and useful. Following the webinar, we will provide links to you to the recording of the webinar, the presentation, and also a report where we will include the questions that we couldn't cover today, and we will also try to address them in that report. When you exit the webinar, you will be requested to complete a brief online survey, and we will be very grateful for your participation so that we can improve the experience of future webinars. The survey also includes an opportunity for you to suggest topics for the next webinar. Thank you again for your participation, and goodbye.